for our monthly Issues in Aging seminar. My name is Brian Carpenter, and I'm one of the co-directors at the Harvey A. Friedman Center for Aging, along with my compatriot Nancy Morrow Howell. Before we get started with the program, we have a couple of announcements and some housekeeping items. So if we could move to the next slide. A couple of upcoming events for the center that we hope you would be interested in. Our next move retirement seminar, the next episode of that is coming up on October 8th out at the St. Louis County Library, the Clark Family Branch. So if you or someone you know is thinking about retirement or getting close to retirement, this is an excellent program to help people think through some of the issues regarding that transition. We'd also like to point out that the annual End of Life Festival is happening on October 4th on the campus it's at the seminary out near Webster Groves, I believe. If you want more information about the schedule for this festival, you can find it online at lastcallendoflifefestival.com. And up next for our Issues in Aging seminar, on October 27th at the same time, we'll be welcoming Dr. Andrea Ford, who will be speaking about her research on brain health, particularly how chronic illness, sickle cell disease in particular, and low socioeconomic status can cause cognitive problems. So we hope you'll join us for that next Issues in Aging as well. So today, before we dig into today's topic, a couple of housekeeping items for you to consider. We're in a Zoom meeting, as you may well be aware. So feel free to turn on your camera if you'd like. We'd like to see your face, but it's not required unless you're applying for continuing education credit for participating in today's seminar. And I'll talk about that in a second. Your microphones will be muted, but you still have the ability to ask questions by typing into the Zoom chat. We'll be monitoring those questions coming into the chat. You should also have received a notification from Zoom that this meeting will be recorded. We have an archive on our website that will include this offering as well as all of our previous Issues in Aging seminars. We're pleased to be offering continuing education credits for this program through the Brown School's Professional Development Program and through the medical school. Our colleague Sarah will be putting information into the chat about the CE policy and any questions that you might have. You can also look back at the email reminder we sent about this program for additional details. To earn your CE certificate, you have to arrive on time, attend the entire course, and complete an online course evaluation at the close. Everyone will be receiving the evaluation, and we appreciate your response, even if you were not collecting CE credits. There's typically a fee associated with these CE units, but the Friedman Center for Aging will cover the $25 fee for this session. And if you have questions about that, you can let us know in the chat and we'll get back in touch with you after the presentation is over. Okay, so on to our speaker and our program. We're so pleased to welcome Bethany Goff here as the Director of Answers, At Home Plus, and Guide at EverTrue Anywhere Care. Bethany brings a wealth of knowledge from more than 30 years of experience working in the St. Louis area with older adults in the community and in healthcare settings. She spent more than half of her career with BJC and was involved in supervising social workers and supporting the implementation of new programs such as the Ortho Bundle, 3-day SNF waiver, and the post-acute care program. Bethany shifted her focus to community programming and supporting organizations to develop their care management models and programs in the community. Bethany is a person who's inspired to work on new programs that can fill gaps in care, provide the right care at the right time, and provide services for everyone, whatever their circumstances. Bethany earned her BSW with a certificate in gerontology from UMSL and an MSW from SLU with a concentration in healthcare and a master's in management in one of the other advanced degrees she's been collecting and leadership from Webster University School of Business and Technology. Bethany's a licensed clinical social worker in both Missouri and Illinois. So, welcome, Bethany. We're so pleased to have you here today and to learn from you this afternoon.
Thank you. I appreciate that, Brian. What a nice introduction. So thank you very much. I'm thrilled to be here to talk about the guide model today. I am also here with one of the social workers on my team. She is a licensed master's social worker as well. Her name is Alex Burkhart. She brings 14 years of experience supporting older adults to age in place. Her work has included crisis intervention, case management, resource navigation. She's served with Missouri's Department of Health and Senior Services and worked for several local nonprofits, including Aging Ahead, Local Area Agency on Aging. She's also a certified information and referral specialist. So I'm thrilled that she's here. She will bring the front-facing view of what we have been experiencing live with the guide model and its launch and the intake process. So very happy to have her here with me today, and I will go ahead and jump right in. I'm going to start real briefly by just saying EverTrue is the organization that we work for, formerly Lutheran Senior Services. We have gone through a rebrand back in March, but nothing else has changed in terms of our leadership, staffing, employees. Everything else is exactly the same. Part of EverTrue, I feel like in the St. Louis community, people are very aware of our life plan communities, less familiar with our full range of services to help older adults age in place, which is what brought me to the organization. It's definitely part of our strategic planning to be able to have whatever care an older adult may need. And definitely wanting to support older adults that are aging in place at home. So just wanted to mention that we have full range of services: hospice, palliative care, Medicare reimbursed home health care, a PACE program, private duty services, and then the services that I oversee. But without further ado, we are here to talk about guide today. So EverTrue and the guide model. Just a little bit about EverTrue, formerly Lutheran Senior Services. We are the 11th largest nonprofit senior living provider in the country. We serve more than 15,000 older adults each year. We've been around 165 years and positioned for a strong future as we continue to grow and add services to our service lines. So, prevalence of dementia. So just a little bit of background on the state of dementia currently in our country. 6.7 million Americans currently live with Alzheimer's or other dementias. This is projected to be 14 million by 2060. 42% of Americans over the age of 55 are going to eventually develop dementia. And this increase we see from we're diagnosing earlier, baby boomers are aging, and increased diversity in research. Dementia and other health conditions. So what we find is people with dementia usually have at least one other chronic illness that they are managing.
Hey,
9 to 5.
Bethany, I'm so sorry
Yeah.
to interrupt. We do not see the
Oh,
slides.
oh my gosh. Wow. That is, sorry about that, guys. Let me go back here. Good now?
Good.
Okay. Thank you, Alex. Appreciate that. All right. Too many screens here. My apologies. So we'll skip back just a little bit. But important to bring up the prevalence of dementia. This is really what inspired us as an organization to apply for this model. It really aligns with a lot of the other work that we do, providing dementia-friendly communities. Back into the health conditions, 95% of people with dementia have one or more chronic health condition, and that's important for a few reasons. Obviously harder for them to manage their conditions. And someone, for example, with diabetes and Alzheimer's costs Medicare 78% more than someone who has diabetes without. And we can imagine why that is. They have challenges managing the chronic disease that they are trying to manage. Maybe they're not taking their medications as appropriately or have the caregiver support to get to physician appointments. Hospital utilization. They have someone with a dementia diagnosis will have twice as many hospitalizations. One study found that 40% of dementia patient hospitalizations were for preventable conditions. So, infections, dehydration, a fall that often is unreported to caregivers. Hospitalization in adults with dementia increase the risk of behavior disturbances from the hospital stay and having some delirium with that, institutionalization, rehospitalization, and death. So all of those things when someone has a dementia diagnosis are increased. And we'll talk about why that's important, and this will lead into why Medicare came up with the guide model. EverTrue as a guide provider, there are a few guide providers in the St. Louis area. For us, this really aligned with what we are already doing in my department in terms of solid holistic care management. We already have a team of social workers providing care management. The guide model calls it care navigation. But we are committed to creating a dementia-friendly community, and that's across all our life plan communities and all of our service lines. And they actually just trademarked the Still You philosophy, which is really, it's been a project in the organization for quite some time now to really make sure that all staff, all employees are equipped to help support someone with a dementia diagnosis. We believe in serving all socioeconomic levels. So we want to have programs that meet people where they are. So we have grant donor funded programs for lower socioeconomic older adults in our community. Guide obviously is a Medicare B covered benefit. And then we also do private pay care management for those that can afford to pay. So anywhere care services support anyone wherever they want to live. So Alex is going to talk a little bit about the cost of caregiving. There's a lot of interesting articles out there right now. So I'm going to turn it over to her to talk a little bit about that.
Thank you. So, yeah, we started with some background information on dementia, but another important piece to the development of guide is really the emphasis on caregivers. So I just wanted to preface that although the next two slides really focus on mental, physical, financial costs to caregiving, I hope that the positive, societal, financial, personal benefits to being an informal caregiver are obvious. We're focusing on the negatives because from a policy and programming standpoint, that's how we know how to support caregivers in that journey. So that being said, it surprises no one that caregivers are more likely to neglect their own health needs. Sleep, diet, exercise, they all go by the wayside when you're trying to manage someone else's needs. Caregivers often cancel or postpone their own medical appointments. I know I've come across a lot of caregivers in my roles who will put off major surgeries, heart surgery, knee replacements, hip replacements, because of their caregiving responsibilities. The main reason I hear is just because they don't have anyone else that can look after their loved one for the weeks or months worth of recovery that might be involved. There's also just an inherent risk of injury when you're helping someone with tasks like transferring or bathing. Interestingly, dementia caregivers themselves are at higher risk of developing dementia compared with the general population. I do want to note correlation does not mean causation. Could very well be due to shared environmental factors, but it is interesting. Next slide, please. So, from the time of diagnosis, the total lifetime cost of care for a person with dementia is about $321,000. 70% of those costs are covered by families and the individual themselves. These costs include medical care, durable medical equipment, supplemental services, facility placement, as well as just the value of informal care. I also want to note this number was actually calculated in 2015, and costs have changed significantly since then. So, for instance, the study that created this number used an average hourly rate of $23 an hour when someone hires a formal caregiver. In 2025, the average cost is closer to $33 an hour. So, certainly this number would be higher if it was recreated today. 40% of caregivers report having to go from full-time to part-time work, and 20% have to quit their jobs altogether. These negative career impacts do disproportionately affect younger caregivers, caregivers of color, and caregivers with lower incomes and educational levels. Next slide, please. So let's talk about some of the services that already exist to help. Home and community-based services is sort of an umbrella term for any kind of person-centered care that helps someone to remain at home safely. So all the listed examples are services that might fall under home and community-based services. I bolded three of them as a bit of dramatic foreshadowing because the guide program actually offers all three of the bolded examples: case management, caregiver training, and respite. Next slide, please. So I want to focus especially on respite care. Going back to when I said that caregivers often neglect their own needs, respite care can definitely help with that. Respite is really any kind of service that provides short-term relief to the caregiver. So it includes adult daycare, short-term stay at an assisted living or a skilled nursing home, a paid caregiver coming to the home. Respite could be hours, it could be days, or even up to a couple weeks. The hardest part about respite is finding help to pay for it. A lot of families that I talk to are quite shocked to find that Medicare does not cover respite um, until Guide, which we'll get into later. But Medicaid, the VA, long-term care insurance, grant programs, those are all potential sources of help, but affordability is definitely a barrier for this service. Next slide, please. So we can see that cost is both a benefit and a challenge of HCBS. Um, these services are absolutely cheaper than nursing home placement, but they're still not affordable. Um, HCBS allows a person to remain living at home or in the community, which is a benefit. Some programs even let family members or friends be reimbursed for their caregiving. Some services come with counseling or spiritual care, such as hospice. That being said, HCBS is limited not just by cost, but also the availability of providers. So, for instance, in Missouri, you're really only going to find adult daycare centers in major metropolitan areas: St. Louis, Kansas City, Columbia. Um, Even if you live in St. Louis County, you might still have a 30-minute drive to the closest adult daycare center. Um, there's also a nationwide shortage of paid caregivers, so whether that's in the nursing home or in the home, and sometimes HCBS itself is still not enough to prevent caregiver burnout. Most of these services that we're talking about here are not 24/7. It's really going to be supplemental care for short-term periods. And lastly, going along with the cost, insurance doesn't cover a lot. So Medicaid and the VA have programs for people. You have to meet certain financial or service qualifications. Even then, that can cover less services than sometimes people hope for. Um, Not everyone has long-term care insurance. Even if you do, sometimes that is also limiting. So next up.
Thanks, Alex. So this brings us to the Medicare Medicaid Innovation Center. So this is where the guide model has originated out of. For If you're not familiar, it is a lot of fun to look on the website and look at some of the different things that the Innovation Center has put out there to try. And the goal is what this means. So all the background about dementia, current state of dementia, rise of people with dementia diagnosis, the cost, mental, physical, financial for caregiver burdens, all came together and caught the eye of Medicare. So really what the Innovation Center wants to do, they're looking at care delivery and what is costing a lot, right? So we can see from all of the statistics about hospitalizations, other comorbidities, rise of cost for all of those things is what caught the attention. So the Innovation Center was established in 2010. Its goal is to improve healthcare quality and reduce the cost. So they're really looking at testing new payment and service delivery models to try to reduce that overall financial burden of Medicare dollars and see if we can do things better. So I had the good fortune of working on one of these programs before the bundle payment for care improvement. This was when orthopedics, we've seen a lot of changes in orthopedic service delivery over the last 10 plus years in terms of knee and hip replacements. And it was also out of the CCMI. And the goal was looking at how to reduce the cost for some of those procedures that have really had a lot of technology advancements, and how can we reduce the time of people in the hospital, still getting them the services that they need. So that was another example more recently that happened to really reduce cost for ortho patients and on the Medicare system itself. Initiative to reduce avoidable hospitalizations among nursing facility residents. So trying to reduce the amount of times that a nursing home patient may be sent to the hospital, back to the nursing facility, and then needing to go back to the hospital for some unresolved issues. So really trying to, provide better service for those people. And then, of course, Guide is one of the new programs that is out of the Innovation Center. So the history of Guide and how it came to be, the Biden administration issued an executive order to increase access to high quality care and supporting caregivers. The national plan to address Alzheimer's disease. In 2016, 2 programs received Healthcare Innovation Awards in dementia care. And in 2020, CMS synthesized 5 dementia care projects in a report, and they found the use of dedicated staff with expertise in dementia led to better care experience. Low engagement with primary care physicians led to limited enrollment. More in-home support and access to respite could strengthen the effects of dementia care projects. And longer follow-up periods may be needed, though, to see the results of this. So this is then what sort of took us into the Guide model and the Innovation Center rolling this out to see if we could tackle some of these issues and have better service delivery for people with a dementia diagnosis. So the timeline, applications opened in 2023. Different providers across the country could enroll or apply to be a provider with either being on a new track or an existing track. So some people that really have worked in the dementia care delivery space, some people started a year before we did. We had a year of implementation. So although we had the care management piece down for the care navigation, what we really wanted to be sure that we were thoughtful and intentional about how we were launching the program through the lens of helping specifically people with a dementia diagnosis and their caregivers. So in 2025, July 1 is when we went live. Participating agencies have to be Medicare B enrolled. So this is a Medicare B add-on benefit. We do bill people under their Medicare B for the services we provide. Across the country, there's 330 providers for the guide model, and it's going to run for 8 years. So 5 key strategies of CMS guide model is one, defining a standardized approach to dementia care delivery for model participants. So staffing considerations, services for older adults with dementia and their unpaid caregivers, providing an alternative payment methodology to model participants. So how we get reimbursed for the work that we do, we'll go into a little bit of more in the next few slides, but the quick answer to that is that we get a monthly amount per aligned patient with a dementia diagnosis, and that helps support the services that we're providing. One of the big goals is addressing the unpaid caregiver needs. So the model really aims to address the burden of the caregiver and what they're experiencing, respite services. And again, these 2 pieces, meeting the unmet needs of the caregiver and the respite reimbursement for those types of services, is what really makes this particular model out of the Innovation Center like no other Medicare program. I really never thought I would see in my career Medicare covering a service for someone that isn't the patient. So for those of you that may work in that space, we know it's all about eligibility, meeting the criteria for services. So the fact that this model is helping the caregiver, who's not the primary patient, and also paying for respite services is really what makes this unique. And a piece that Medicare does want to really pay attention to is social determinants of health, and we use the screening for health-related social needs. So what is GUIDE? Stands for Guiding an Improved Dementia Experience, supporting people with dementia and their unpaid caregivers. And 3 main goals here. It's 1, improving the quality of life for the person with dementia, but also reducing the strain on the unpaid caregiver, and empowering people with dementia to remain in their homes and communities. So again, the guide model, and in the eyes of Medicare, wants to provide better service, better care, and reduce cost. So if we address the caregiver burden and we can help prevent people from going to a nursing home if it is not really what they want to do, but feel that they really have no other choice. That is also a cost savings, as Alex talked about. It's generally less expensive, although the cost of in-home assistance is really on the rise, but it is generally financially better to keep someone at home if the caregiver can do that. So we offer care navigation and care coordination, caregiver education and support, which is a really big piece of this program for us, and then the respite services. So these are the main components, and we'll talk a little bit about how we provide this to the people that we're serving. They will, and Alex will talk a little bit about what it looks like and the types of calls we're getting and from where. But once we have verified that the person has a dementia diagnosis, that they have traditional Medicare, and that they're living in the community, not in a nursing home or hospice or under hospice care, we will have one of our social workers, our care navigators, go out to do a home assessment and meet the patient and the caregiver in their home, complete an array of assessments, which we'll review here, and create a care plan. They're going to talk to the caregiver and also do an assessment to try to gauge how that caregiver is doing. The respite services, not everyone, but many of the guide patients will be eligible to receive financial assistance for the respite services. The care coordination and support, so getting connected, again, it really all goes back to just solid care management, looking at the patient and the caregiver holistically, getting them connected with either services that we have in-house if we have them, or getting them connected to other community resources, and then 24/7 access. So we all are on call. We also have a platform that we'll talk about in a little bit where caregivers can reach out to get questions answered and get the support that they need. So eligibility is super simple, does not require a physician order, which is also unique for this. Now, we do partner with the primary care physician for that person, and we definitely want them involved, and we'll talk about that too. But they just need to have a confirmed diagnosis. We'll look at the list of those diagnosis codes. There's a lot of them, so it is very encompassing. They have to be traditional Medicare. So what we see, one of our challenges in the St. Louis area is the high penetration of Advantage plans. So this is not a program for Advantage plans. This is something really only for people that are enrolled in traditional Medicare, as it's out of the Innovation Center for CMS. They can't be on hospice, in a long-term nursing home, or part of our PACE program. And the reason for that is Medicare is already paying for a whole array of other services for people that might be connected that way. So we won't go through all of these, of course, but this is really just to give you all an idea of how encompassing the list of the diagnosis codes are. So usually we get this from the physician on the history and physical list of medications, and that generally is enough to get us started to start meeting with the patient and their caregiver and trying to get them connected with services. So we've got 3 slides here of different diagnoses. So the guide benefits and services that we provide is care navigation. It is important to know, and we get asked this a lot, if they maintain their primary care physician, and they in fact do. So this doesn't really change anything. Again, this is just an add-on Medicare covered benefit for anyone with a dementia diagnosis. The care navigator is going to be the primary contact. In our case, delivering this program as a community-based organization. We will meet and conduct the initial assessment, and then annually, or if there's a change of condition, and those changes of condition might be change of caregiver, or a worsening or progression of behavioral disturbances with the dementia diagnosis. Standard check-in is at least once a month. So the care navigators are making telephone outreach to the caregiver or the patient every month to check in, ask if there's been any changes, any updates to medications, etc. And then providing support and education tailored to patients' needs, such as care planning, safety planning, and resource connection. So Medicare gave us a list of assessments that we are required to do. We still have a lot of phone calls and a lot of webinars through Medicare to make sure that we are in compliance and doing everything that we are supposed to do. These are the assessments that are required. So we already had a very holistic care management assessment through a social work lens. So we know how to get the information to really address all needs. But in addition to that, Medicare, of course, wants some of the standardized assessments done so that they can look at performance outcome measures, which we just had a call about today. So again, always learning. And at some point, they will be looking at the performance outcomes, again, to see if this is successful in solving to the problem. So the health risk needs assessment, we talked about that earlier, talks a lot, there's a lot about social determinants of health and making sure that we're addressing those issues or needs. The FAST, the Zaret burden interview, that is a caregiver burden test, and then patient reported outcomes measurement information system. And all of this is done at the home visit by the care navigator. So the FAST is 7-stage rating scale for any form of dementia. So that's based on observation during that home visit. The ZBI is self-reported measure for caregiver burden. So the caregiver works with the social worker to get that completed. So we have an idea of how well they are managing their stress. And then the promise assesses healthcare related quality of life for those with chronic conditions. And it is one of our guide performance measures. So once we do all of that, so the social worker's gone out, we've completed all the assessments, everything gets entered into our electronic health record. We have our physician attest to verify all of the information and its accuracy. We send it all into Medicare, and then we wait 15 business days or more, depending. It's been a little slow roll here in the beginning. But then they come back to us and they weigh all of those pieces in. What were the results of the assessments? What's the situation with the caregiver? What is where is the patient with dementia and the prognosis of their disease? Where do they live? Are they live in a lower socioeconomic area or not? So they put all of this together and they come back and they give us a tier level. The tier level, low, moderate, high, and with a caregiver or without a caregiver. And why this is important. One, this impacts our reimbursement. So this determines how much we are reimbursed to provide the guide model for that recipient. And then it also is going to let us know who's eligible for respite. So only people with a caregiver, of course, because that's what respite is for, that are in the moderate and high tier will get the financial assistance with respite services. Just a little more detail on that. You can see over on the right-hand column, those are the results that they're looking for in the assessments. So part of what Medicare really wants to see as well is the interdisciplinary team approach. Now you have to remember all sorts of different organizations, including physician offices, were able to apply and become a provider for this program. We, as an organization, as a community-based organization, our service delivery looks just a little bit different because we're not the primary care physician office. And for those people, that process and that workflow looks a little different. But regardless of what type of organization you are providing the guide model, you are required to have an interdisciplinary team approach. So standardized set of services, which we have IDT meetings every week to meet with our medical director. The care navigators, I mean, we are fortunate that we have master's level social workers who are our care navigators, but despite that, we still had a full range of education that they had to complete that was very specific to caring for someone with a dementia diagnosis, and we create a care plan. So we have our IDT meetings, and then we will update the primary care physicians so they know that their patient has been aligned to the model and that our medical director has reviewed medications, and then any notes or suggestions that he has, we'll be sure to relay that to the primary care doctor. And this is Dr. Kaiser. So he has been a pleasure to work with. He is our hospice and palliative care medical director at EverTrue as well. He's a geriatrician, over 30 years experience. Again, people keep their own physicians, so they still have that support. This is just adding an extra layer, an extra physician to be able to look and review medications. And he's worked a lot in the dementia care space, so he really can perhaps bring some other suggestions to the primary care doctor. All right. And then this is our caregiver support platform. So Alex is going to talk a little bit about how we're providing caregiver support to the caregivers of our patients, and then also a little bit about how our intake process has been going.
Yeah, absolutely. I'll just note, I know there's been a few more questions in the chat. We'll try to answer all of them at the end, so I appreciate it. Anyway, so another benefit through Guide is EverTrue has partnered with a company called True Alta. And what True Alta does is offer essentially caregiver support. So they have an online database. Um, they have support groups. They have caregiver forums. They have a lot of practical resources, so trainings on any number of different topic, pretty much any dementia-related behavior you can think of, they've got a training for. So how to work with someone who's resistant to taking medications or responding to swearing, for instance. They also have a lot of virtual and local self-care opportunities. I saw on there they had a book club, they had live guided meditations for caregivers. Um, you can also talk to a care coach one-on-one. Another great thing about True that I liked is that all interactions can be anonymous. So you can register with your name, but you can also choose to remain anonymous on all of these supports, which I think is great for caregivers who, may feel some type of way about the things that they're experiencing. I think that there can unfortunately be some shame or some burden that people take on when we're talking about these more negative dementia related behaviors. So it's just a nice benefit that True thought of. Next slide.
And I will jump into one thing I
Yeah.
love. We've enrolled a few people, few caregivers that have enrolled into the True platform, and we're able to get feedback on what types of things they're engaging with on the platform, which helps us to know if this is a successful platform for them or not. It also gives the care navigators some insight into what types of things they're seeking out. So if it is a particular behavior, they know on that monthly touch point it's something that they maybe want to talk about and help find some additional resources for them.
So the next benefit, the biggie, the selling point of the program is respite support. As Bethany mentioned earlier, there are some specific qualifications for CMS to approve respite support for a patient or their family. But Medicare sets this dollar amount. As of June, it was up to 2,563 a year. That is an annual amount. And families can choose to put this towards having an in-home caregiver come to provide respite, a short-term facility stay, or going to an adult day facility. Um, I never want to I never want to diminish that amount because again, as we've talked about, this is more than Medicare has ever allotted for respite care. But I do want to acknowledge as well that that dollar amount doesn't necessarily go as far as some people might hope. So all that to say is it's wonderful to have that support. And the care navigators can also be there to help to find other methods of support. So they're there to also assess for eligibility into Medicare, VA, other grant programs. So just want to note that. So basically, folks remain enrolled in Guide. Again, it's an 8-year model, and the 8 years technically started in 2014, so we've got a ways to go. But people remain enrolled as long as they are engaged with their care navigator. So they got to return our calls. Um, they have to complete their annual reassessment. We can reassess more often as needed, but you have to at least do that reassessment once a year. And they also just have to meet that Medicare eligibility. So they have to continue to have original Medicare A and B. They can't continue to have Guide if move into a long-term care facility, a nursing home specifically, or if they enroll in hospice or PACE. Next slide. So through EverTrue, we found it helpful to just kind of lay out what this enrollment process looks like. So first of all, patients, caregivers, providers, again, through EverTrue, should call our guide intake line. The phone numbers on the screen. That's really the starting point. It's often me that answers that line, so you might be lucky enough to talk with me. But I can provide, information on eligibility, as well as, start the enrollment process. After that, we work with the patient's physician office. So we need a history and physical, and that needs to include the dementia diagnosis and the medication list. We need that faxed over. Um, the care navigator will work with families to obtain this information. It's just essentially one of the requirements of the guide program, again, was having that official dementia diagnosis. So it goes hand in hand with Dr. Kaiser having uh, being able to provide input on that disease process. Um, then a care navigator will schedule that home visit. They'll complete the initial assessment and care plan with the person. And from there, everything is sent off to CMS. CMS are the ones that assign a tier level and basically give final approval for the program. The care navigator is then in touch with the patient and their caregiver with that determination. Okay, now we have space for questions. So I know there were a couple. I don't know if you want to go back and forth or if you want to start looking through them, Bethany.
Let me
Alex, would it
stop
be okay if
there.
Yeah.
I was just going to say, since not everyone may have read the chat, we could just read, I'll
Oh,
just
yeah.
read some of the comments and questions out while other people are thinking about what else they might want to ask. The first question was, will federal funding still be in place for this program going forward?
Great question. Fingers crossed. It's still happening now. We've heard
Yeah.
nothing to the contrary, but we were a little nervous, of course, as we started getting close to launch after spending a year to really be thoughtful about how we're providing this care for patients and their caregivers. So far, so good. But yes, great question. And we all kind of wonder.
Great. I'm just also going to reiterate that we will have the slides available, and we're also going to have the recording available on the website. So rest assured you'll get those details. Deb commented that it's important to note that respite care actually does help the person with dementia. It provides breaks for them from the primary caregiver, can provide socialization, and gets them accustomed to getting support from others. Want to make sure everyone heard that, and if Bethany and Alex want to add anything to that, you're welcome to.
Yes, I will just say the only thing to pay attention to there is if the person with dementia, which our very first patient did not have a caregiver, in order to receive the respite benefits. So in this space, they have to have a caregiver. Otherwise, they're not eligible for that. But yes, great point.
Thank you. Michelle asked about whether the person with dementia has to be a specific fast stage. You did show that on your slide. I don't know if you're able to show that again, or if you want to speak to that.
Yes, they changed that actually. And do you remember what the new amount was, Alex? Or I can try to pull it back up here. Bear with me.
And while you're doing that, can a potential participant get a diagnosis through guide if they don't already have one, or do they need to already have that diagnosis?
They do need to have the diagnosis.
Okay. In more rural
Sorry.
areas, sure. In the more rural areas, is the initial assessment still done in person or via telehealth?
Well, that is really interesting because there are some other providers, some of the I apologize. I can't share my screen again. I can tell you what the FAST score is. It's a FAST of 4. It has to at least be the FAST of 4 um, on the low complexity. Was that that question?
I believe so, yeah.
Okay. In terms of the rural areas, there are some other providers. Ripple is a national organization that's partnered with Alzheimer's Association. Home visits are required. So one thing I will just say, the like the 3-day sniff waiver, it was actually a program Medicare payment model that I worked on at BJC. What was different is we had to be an ACO to do it. So who applied for it? It was more managed. What we see with Guide, which is really interesting, is that a lot of different types of organizations could apply to be a Guide provider. The service delivery of how different organizations are doing it is wildly different. We are doing it. Our best practice is that we want people to receive holistic care, just how we provide care management for every other client that we serve, regardless of their payer source, where a lot of these other larger organizations are contracting that out. So it's a little once removed. So, in answer to your question, the rural areas, yes, they can receive the service. How they're doing home visits, I can't really speak to because I'm not really sure, but it's a valid question. And also, I would say in the rural areas, having the respite, we have to have contracts with anyone that provides the respite services. So we do not, although we will get an adult day center contracted with. We're fortunate that we have our own in-house private duty services that we're able to utilize to provide the respite services. But in rural areas, that has been a challenge, even finding a partner agency to provide the respite services. So definitely a challenge.
Thank you. We also reiterated that this is for folks with Medicare, straight Medicare, not Medicare Advantage.
Yes.
Open enrollment is coming. I don't know if you want to speak to that at all, and if that might be an opportunity for folks.
It certainly could be. We've had some conversations about this, and I don't know if this program in and of itself is going to be enough of a motivator for people to switch from their Advantage plans. What we find, particularly with our lower socioeconomic older adults, these gift cards are powerful that they are giving them for food. Really, for our PACE program, it has also been a challenge, the high amount of Advantage plans in the St. Louis metro. So I don't know. So they certainly could switch, but we have found, and Alex, you can speak to this too. You talk to a lot of people that have called that have Advantage plans. I don't know if they've voiced any sway to be able to receive this service or not.
Yeah, I would say that's the number one reason when people call and they don't qualify for the program, it's typically because they have an Advantage plan and not original Medicare. Um, and, I say the same thing to them. You certainly could look at changing your insurance plan during open enrollment, but that I would caution them to really think through all the benefits, because obviously that affects quite a few different things in terms of medical care. So, yeah, I don't know. I can't say for someone if it's worth changing their insurance just for Guide, but um, it's something to consider. Yeah.
Mhm. Question.
Are there any questions? We've got one question in the chat, but want to make sure people who are not using the chat have an opportunity to unmute and ask a question. And then we'll get to that other question in the chat.
Oh, thank you, Brian, for posting that spreadsheet. Yes, the CMS website does have a full listing of all the Guide providers across the country.
Great. Thanks, Brian. It's funny, we do get people that are just hearing about it in the St. Louis area. Medicare is supposed to send letters out that will also give all Medicare beneficiaries in our area a list of the local providers. but we do get people call. Like, I have an aunt, she lives in Michigan. So been out and about in the community quite a bit just talking. So yes, we can usually, if people call us, we will try to get them to a guide provider in whatever part of the country they're in. So thank you for sharing that.
Sarah, if I could jump in, Deb Breyer wondered about getting the challenges around getting a diagnosis. And it doesn't sound like the guide program is the resource there to help with that. But Bethany or Alex, maybe you want to talk about whether EverTrue has any resources to help people get a diagnosis.
So I guess a couple things. One, we have found success with our physician offices because they are already identifying someone who has the diagnosis. So if someone doesn't have a diagnosis, yes, it can be a challenge then to start traveling that path to get the diagnosis. We do not current state have the means to do the diagnosing. It's not a space that we decided to at least start. We kind of want to get our feet wet, make sure just our service delivery is really good for the patients and the caregivers. Um, of note, palliative care, our palliative care program is just booming. We just hired a third nurse practitioner. Our palliative care is in our own communities, but also out in the St. Louis metro area as well. So I see some more alignment with our palliative care patients. So we could eventually move into that space of looking at trying to help get a diagnosis for someone or work with that patient and caregiver to do that, but not right now. But definitely acknowledge that that would be huge for people. Yes.
Thank you, Bethany. We've got our final question from Andrea.
Hi, great presentation. Thank you. I was wondering if the ships, that advise people on Medicare throughout the states, are they pretty surely are getting familiar with the guide program? And just because, as you say, so many people come to us on Advantage plans, and now that we have this big benefit, of course, people don't know when they're starting enrollment necessarily they're going to have dementia or their loved one is. But I just didn't know if you all are kind of working with them in any way to be sure they're able to advise on this as well.
That's a great question. I have not talked with them. Alex, have you talked with them lately?
I
Claudia?
have not. I saw Wilma Schmitz a few months ago, but I don't think guide came up in the conversation.
Just a thought. Thank you.
Yeah, thank you, Andrea.
And we're just about at time. So again, I want to thank our speakers, Bethany and Alex, for sharing their expertise and information with us today. As Sarah mentioned, we'll have this webinar archived on the Center for Aging's website. For those of you who are seeking CE credits, please make sure that you complete the evaluation that you'll be getting by email. And of course, we'd also appreciate any feedback or input from others on that evaluation form as well. Thanks all for joining us this afternoon, and we'll hope to see you again in an upcoming Center for Aging program. Take care, everyone.
Thank you. Bye-bye.
Thank you.
Okay, well, welcome everyone, and thank you for joining us today